All right, one of our last topics is talking about needle chest decompression. There's been a lot of discussion with this, both with our trauma surgeons and trauma surgeons around the state. We're actually working on a position statement with the EMS Medical Directors Advisory Council regarding this because we've had some complications around the state from needle chest decompression. It's a high-risk procedure. A lot of paramedics go their whole entire career without ever performing it, and so it's very important that you know how to do it, when to do it, and the landmarks that you need to use for it.
And the landmarks is the biggest issue.
So when do you do it? They really have to have signs of a tension pneumothorax, and I'm not talking about a simple pneumothorax because that's not an indication for field chest decompression. So respiratory distress, they have absent or really markedly diminished breath sounds. They're usually hypotensive and they have jugular venous distension. Now if they're in hemorrhagic shock and they have a pneumo, they're probably not going to have JVD with that, so you can't completely rely on that. And then the other indication is a traumatic cardiac arrest, where if you think that they have chest injuries, they really should be getting needles in both sides of their chest with that, if you think that they have chest injuries.
And that is our protocol on all traumatic arrests before we call them in the field, that they have to be bilaterally decompressed before we say.
Right. And then I'll reiterate this point that diminished breath sounds is not an indication for decompression. You really have to have the physiologic changes of tension pneumothorax, because this is really a life-saving temporary relief of a pneumothorax until they get a chest tube inserted.
Now, I know a lot of the paramedic schools, a lot of the new paramedics come out and they're always like, you know, besides the JVD and some hypotension, they're always like, oh, the tracheal is going to be deviated. In all the clinical stuff that I've ever read, that deviates when they're in the morgue, pretty much.
Pretty much, yeah. I've never seen that, tracheal deviation, and it's almost always a near mortal event when they have that. It's a fatal event. So where do you decompress the chest? There's a lot of, it seems like the lateral chest decompression is in vogue with everything. This started with TCCC. You know, think about the military. They've got healthy young males that are fit, are wearing body armor. It's a lot easier to needle decompress the lateral aspects, but that's not what we really have in our community. I mean, you think of the 75-year-old with cardiomegaly and CHF whose heart is, you know, right up against the chest wall because it's so large, and their own blood thinners. It's a totally different population with it. Our trauma surgeons here in Cobb County prefer the anterior approach, and I'll show you some pictures why here in a few minutes, but both of them are an option. We are going to introduce a tool to help you with the lateral approach if that's the way to decide, or the route that you decide to go. And there are some times that the lateral approach would be beneficial. If you have a police officer and you can't get their body armor off because you're under fire, you know, lateral approach is more applicable, and sometimes breast tissue may get in the way as well.
Yeah, I know that's exactly why the military does it, because they're going to decompress you and then button you back up. And if they button you back up in your midclavicular, the body armor is going right over it, and it's basically worthless.
Right.
So, yeah.
So this is a picture of a lateral decompression here, if you can follow the catheter as it goes into the stomach. This is one of the patients who unfortunately had to go to the OR because of this. It's something that we want to prevent, and in this situation the paramedic was too low in the decompression. I think a lot of us don't realize that how high up the fifth intercostal space is, because you're really about the nipple line or slightly above it. In this case, the patient was decompressed low.
Wow.
For that. And this is how the thoracite is going to help us identify our landmarks as well. Here you can see the needle comes in, and it kind of got this is the spleen here, it kind of got the tip of the spleen, or it looked like it on CT imaging. This patient had to go to the OR for exploration.
Wow.
It turns out that once they got in the OR, it actually didn't hit the spleen, but unfortunately it kind of led them to go to the OR. And again, it was all because they were too low, and the thoracite hopefully will help with that. In speaking to the medical director for Los Angeles County, he's had great success with this, which is how we kind of got introduced to it.
Perfect. And we'll be showing you guys that device here in just a little bit to make it very, very simple.
So as I mentioned before, anterior is preferred. The lateral studies have been done on military recruits with a little bit better success with that. The research is mixed on the latest research of which is better, and it kind of goes back and forth. Some studies say anterior is better, some say lateral is better. An interesting study, though, with paramedics that they took 20 paramedics and asked them to identify landmarks, and out of 40 landmarks that they identified, only 5% were correct.
Really?
So this is another reason why we're emphasizing the need to get proper landmarks. I often hear paramedics say that they want to, what if the patient has a hemothorax? A 14 gauge isn't going to really drain a hemothorax.
No, if anything, clot.
Right. It's going to clot up. It's just, if you think of an IV, you get an IV catheter, it's going to clot up after a while with that. So it's really not the best thing for a hemothorax. A hemothorax, you're never going to get a tension hemothorax unless it's kind of like the tracheal deviation. You're almost dead when you get that.
Gotcha.
This is the thoracic that we'll be introducing here in a second. Basically, it goes underneath the armpit, and you'll have a little window here that will allow you to know where to go for proper decompression, so that way you can avoid being too low, injuring the spleen or the stomach, or another case where we had that injured the kidney.
Correct.
This will help prevent that.
We'll also be introducing our new decompression needle, which I actually really like, and it's actually got little holes situated in every space, so that way if the chest wall cavity collapses the very distal end, it will still evacuate that air that's in there. All right, so currently right now in all the apparatuses is we have the decompression needle that you guys are very, very familiar with. But we are now getting our new decompression needles. They're the same thing, 10 gauge, 3 1/4 inch needle. What I want to notice and show you guys is how they are. So these little black lines are actually a little thicker. They're almost like a ridge, and that will actually prevent the intercostal muscles from actually collapsing the actual catheter. And then it's going to be a little hard to see, and when you guys have it, you'll actually be able to see there's little holes that are in opposite directions all the way down. So even if the catheter at the very distal end gets collapsed, you can still evacuate airs through the sides, almost like a Murphy's eye on your endotracheal tubes. I'll let you.
Don't poke yourself.
I know.
That would hurt. That's a big needle.
Yeah.
Do you remember when we used to do 10 gauges in the field?
Oh, yeah.
Loved that. I showed Corey one I still had, and he was like, "Oh, love of God, Dave."
Like a McDonald's straw.
Yeah. So once again, Doc talked about where we're going to be doing our decompressions at, but if we do, and the protocols are very clear, so we're going to have somebody with either body armor that we have to actually just open it up, decompress them, and then put the body armor back on.
Right.
But I also know we've talked about very obese patients,
Mm-hmm.
or like you said a minute ago, a woman with a lot of breast tissue that's going to be in the way, then you can actually go there. So right now on going out to all the stations, you're actually going to have the SAM thoracic. In each packet is 5, and we want you guys to actually open it up to get one out. This is a very, very simple thing. I wish we would have came up with it. What a $1 million idea. It's very simple. It actually will say on it, one side will say right, and then the other side will say left. Very, very simple. As soon as we put this in up underneath the armpit, arm at a 90 degrees, the little hook will go up under that armpit. As long as you have this arrow going towards the hip, there's your window. Now, the biggest thing that I've seen when I read all the literature was, what happens if you can't identify that? Oh, is that the fifth? Is that we're cool with going straight in the middle.
Correct.
So very, very simplistic. We'll show you on a mannequin. We'll show you on me, not decompressing me, but we'll show you how simple it is. It's all about the hip and the armpit. So if you do decide to do the lateral approach, I know the protocol says that you're going to have to document very well why you decide to do the lateral approach. So just remember that. If the patient needs it and they qualify for JVDs, completely absent breath sounds, you cannot do midclavicular, then you're okay with the lateral.
Correct.
Just still got to do good documentation. But the device is very, very simple. Patient's right shoulder, arm's going to be out at 90 degrees, because if you raise the arm up, then the actual armpit will actually change spots. But 90 degrees, you're going to put it in, align it with the hips, and then there is your site.
And these cards can go both on the left and right side. You can flip them over. And as long as you remember that the writing is down or correct way orientation, that you could read it, it's not upside down, then you will have it in the correct position. If you look at the literature, it says anterior axillary line. It's actually a middle in between the middle and anterior axillary line that you're trying to go, because the anterior axillary line is pretty far anterior for that.
And I know the only reason that came out with TCCC is because of the side armor. And so
Correct.
that's why they kept moving it up. But like the doc was saying, if you're in the correct spot, if you notice, I can read everything. If I flip it over, the writing is backwards, and look how high I'm going to be up. Now I'm up in here. Remember, this has got to be aligned with the hip. This is not in line with your hip. This is going to be in line with your hip. And then, Doc, if you want to show them how simple it is if you have an actual person here.
So basically you would take it. I'm making sure that I can read it with the patient's towards its back. Place right there, and then that gives you the place to go. It's very simple.
And where's the hip?
Hip is down there.
Straight.
Thanks
No
for wearing
brainer.
deodorant today.
You're welcome, sir.
This is not for anterior use, obviously. A lot of people do have trouble identifying the anterior landmarks as well. Just remember when you do that the clavicle is pretty far. Mid-clavicular is about here. If you feel your clavicle go down one, you're at one rib space. Here you're at the second, so you can see how high that is. I've seen needle decompression where people come in with needles down here, and the second intercostal space is pretty high.